Hey, welcome to Not So Complicated, and we are doing study with me series of USMLE First Aid Step 1, and we have completed our general principles of pathology and also cardiovascular pathology, and now we are tapping into respiratory pathology. So without delay, we will cover the respiratory pathology, but in two parts. Today we are doing the first part, and I will be doing second part tomorrow. So stay with me, and let's begin. So we begin from rhinosinusitis. What is rhinosinusitis? It is actually an obstruction of sinus drainage into nasal cavity, right? And then it is due to the inflammation and pain over. If it causes inflammation and pain over affected area, it typically affects maxillary sinuses, which drain against gravity due to ostia located superomedially. Red arrow points to the fluid-filled right maxillary sinus right here. This maxillary sinus, there is fluid in this maxillary sinus right here. So basically the most common sinus that is affected by a rhinosinusitis is maxillary sinus, right? And in the there is actually hiatus semilunaris in our nose, in the lateral septum of our nose, and thus there are three openings in that hiatus semilunaris, and also there are three meatuses, which are superior meatus, and then middle meatus, and then inferior meatus. And hiatus semilunaris is present in middle meatus, and actually the superior meatus drains posterior ethmoid sinuses, and then middle meatus drains frontal sinus, maxillary sinus, and anterior ethmoid sinus, and inferior meatus drains to the nasolacrimal duct, right? So that maxillary sinus we talked about, it is drained by middle meatus. And acute rhinosinusitis is most commonly caused by viruses. Example, rhinoviruses may lead to superimposed bacterial infection, most commonly non-typable Haemophilus influenza virus, Streptococcus pneumoniae virus, and also Mycoplasma catarrhalis. These are most common viruses that cause acute rhinosinusitis. We have to cover it up. And also these viruses or bacteria pathogen are non-typable. The most common bacterial infection are often by non-typable bacteria, right? And also paranasal sinus infections may extend to the orbits. They can extend to orbits, cavernous sinus, and also brain causing complications like orbital cellulitis and cavernous sinus syndrome, and also meningitis. So we have another one, sphenoid sinus. We have sphenoid sinus and paranaxal sinuses. So basically that if the infection extends, that sphenous sinus can cause, or cavernous sinus can cause infections to orbits and also brain, like orbital cellulitis and cavernous sinus syndrome, right? So here is another topic we will tap into, epistaxis. Epistaxis is actually simply, it is nose bleed, and then the most commonly occurs in anterior segment of nostril, because it has something called Kieselbach's plexus, or which we also call little seria. And it has a network, it has a plexus of arteries actually, and these plexus of arteries can are very prone to bleed even in minor trauma. So but it can also cause life-threatening hemorrhages occur in posterior segment, that is sphenopalatine artery, a branch of maxillary artery. So basically if we prick our nose and then we hit an artery like this, sphenopalatine artery, a branch of maxillary artery, then it can cause life-threatening hemorrhage because the bleeding is so hard to stop if it occurs. And common causes include foreign body trauma, allergic rhinitis, and then nasal angiofibromas, which is more common in adolescent males. So Kieselbach's area actually has this network of arteries. What are these arteries? We can remember by this mnemonics right here. Kieselbach drives his Lexus with his legs. So drives his Lexus means Kieselbach's plexus, and then with his legs, right? So L for superior labile artery, it is either anterior or posterior. So anterior and posterior superior labile artery. E for ethmoidal arteries, we have many ethmoidal arteries in there. and then G for greater palatine artery, and then S for sphenopalatine artery. You can look at this superior labial artery, here it is, L for legs, and then we have ethmoidal arteries. This is anterior ethmoidal artery, this is posterior ethmoidal artery, this is E for legs, E for anterior ethmoidal artery, and then posterior ethmoidal arteries. Then G for greater palatine artery. This gets into the little's area from palatine region, and then there is sphenopalatine artery. This here is sphenoid sinus that we have, and this here is the frontal sinus that we have. This plexus forms this area called Kieselwachs or Little's area. This is very prone to nosebleed. And let's go to the head and neck cancer. So mostly squamous cell cancer. Head and neck cancer is most commonly squamous cell cancer, and the risk factors include tobacco, alcohol, HPV, human papilloma virus 16, oropharyngeal, and then Epstein-Barr virus, which causes naropharyngeal carcinoma. So basically, here is human papilloma virus 16, which causes oropharyngeal carcinoma, and then Epstein-Barr virus, which causes nasopharyngeal carcinoma. And then there is a term called field cancerization. This is very high yield. It is straight from Robinson Croton books of pathology. So field cancerization means carcinogen damages wide mucosal area that leads to multiple tumors develop independently after exposure. So there are these tumors. These are multiple tumors, and they develop very much independently. That is called field cancerization, because carcinogen attacks this wide mucosal area right here. That causes field cancerization, and that is what we have to remember. And the nasopharyngeal carcinoma may present with unilateral nasal obstruction, discharge, epistaxis. Then eustachian tube obstruction may lead to otitis media with or without effusion, then hearing loss. This nasopharyngeal carcinoma, since it is nasopharynx, there here we have, this is nasopharynx, right? This here, the uppermost part of pharynx is nasopharynx, then oropharynx, then laryngopharynx, right? So if a tumor is in nasopharynx, it may present with unilateral nasal obstruction, because the tumor may extend to the nasal region, right? So, and also there may be discharge and bleeding due to the compression of tumor, and eustachian tube obstruction, because there is meatus in here, superior, inferior, middle meatus, and there is the opening of eustachian tube right there. And if the eustachian tube is obstructed by a tumor in nasopharyngeal region, then it can cause repeated otitis media with or without effusion, and also hearing loss, right? And there is laryngeal papillomatosis, which is also in head and neck cancer. Laryngeal papillomatosis, also called recurrent respiratory papillomatosis, because it occurs times and again. So papillomatosis means there is a papilloma. Papilloma is a budding of tumor, like a mushroom. You can remember that. Suppose this is a skin surface, and this is a papilloma, right? Papilloma can be stalked papilloma, or it can be fused papilloma without any stalk. And then benign laryngeal tumor, this is very benign, and it commonly affecting areas of stratified squamous epithelium, such as the tube vocal cords, especially in children, possibly from human papilloma virus transmitted from mother to baby during labor. So associated with HPV-6 and HPV-11, symptoms may guide location of pathology, which is supraglottic to dysphagia, infraglottic or glottic to hoarseness. That is what it is. We have to remember this, right? So symptoms may guide location of pathology. So if it is supraglottic, if the tumor is supraglottic, if a papilloma in laryngeal papillomatosis is supraglottic, then it causes dysphagia, which is difficulty in swallowing. And there is the difference between dysphagia and odynophagia. Odynophagia is painful swallowing, while dysphagia is difficulty in swallowing. And if the tumor is in infraglottic or glottic region, it causes hoarseness, right? That is it in head and neck cancer. Let's go to the pulmonary emboli. So we all know what emboli is. emboli is something that is detached from the thrombus, right? It is just a thrombus, but it is detached from the place of its origin. So emboli causes actually obstruction. If it is pulmonary, it is related to the pulmonary artery. Obviously, it causes obstruction of pulmonary artery or its branches by foreign material, usually thrombus, as I said earlier, that originated elsewhere. That is the most common cause of pulmonary emboli. And affected alveoli are actually ventilated but not perfused. Since this is an artery, for example, this is a pulmonary artery, then there is this emboli, right? So it is properly ventilated because there is no any pathology in the alveoli and lungs region, in the pulmonary region, but there is pathology in the arterial region. So ventilation is perfectly normal, but perfusion is not done because of the obstruction to the flow of blood in these arteries, and that causes VQ mismatch, which is ventilation perfusion mismatch, and it may present with sudden onset dyspnea, which is difficulty in breathing, and pleuritic chest pain, and then tachypnea, which is increased breathing rate, tachycardia, increased heart rate, hypoxemia, decreased partial pressure of oxygen. Actually, decreased partial pressure of oxygen, hypoxemia is in hypoxemia, if the partial pressure of oxygen is less than 60 mmHg, that is hypoxemia. And if the partial pressure of carbon dioxide is greater than 50 mmHg, then that is called hypercapnia. You can note it down. So there are two types of respiratory failure, type 1 and type 2. Then type 1 is actually hypoxemic respiratory failure, and type 2 is hypercapnic respiratory failure. And it can cause respiratory alkalosis. Why respiratory alkalosis? Because there is difficulty in breathing, right? Difficulty in breathing will lead to hyperventilation. Then increase in ventilation, hyperventilation, increase in ventilation causes rapid breathing, that leads to the exhalation of carbon dioxide at most. And then, since we all know that carbon dioxide is acidic in nature, then increase in respiratory rate causes alkalosis. That is the reason. And large emboli or saddle embolus, red arrows show filling defects in A. Right here are filling defects right here, right? So large emboli or saddle embolus may cause sudden death due to clot preventing blood from filling left ventricle, and increased right ventricular size further compromising left ventricle filling. That is, obstructive shock can happen. So one of the most common complication of pulmonary embolism is obstructive shock, and we cannot set this into the dark. So we have to remember this, right? So CT pulmonary angiography is imaging test of choice for pulmonary embolism. We have to look for filling defects. So what is the gold standard? Is CT pulmonary angiography. And the B, ECG may show sinus tachycardia, or less commonly S1Q3T3 abnormality. So ECG, it is not always present, but this sign is present in some cases, S1Q3T3 abnormality. So it is actually McGinn-White sign. It is also called McGinn McGinn-White sign, and it shows S wave depression in lead 1, and Q3 in Q wave in lead 3, and T wave inversion in lead 3. So that is McGinn-White sign. It occurs in pulmonary embolism. That is classic feature of this disease. And there are lines of Zahn. Lines of Zahn are actually interdigitating areas of pink and red. So pink is due to predilection fibrin, and red is due to RBCs found only in thrombi formed before death. So basically, if we can distinguish if the thrombus is formed before death or after death, if there is presence of lines of Zahn, that indicates that the thrombus is formed before death, and if there is absence of lines of Zahn, that means the thrombus is formed after death, and it helps from pre and postmortem thrombi distinguishing. So the treatment of pulmonary embolism, since it is almost always a thrombus, there should be an anticoagulation drug like heparin or low molecular weight heparin like apixaban, and also direct thrombin or factor X inhibitors, and inferior vena cava filter if anticoagulation is contraindicated. We have to do that. And there are types of pulmonary embolism which is which is remembered like this: fat pad. So F for fat embolism, and then A for air embolism, T for thrombus embolism, B for bacteria, vegetations, and then amniotic fluid, T for tumor. So if it is a tumor that is being metastasized, that is tumor embolism. Fat embolism also is there, and air embolism actually occurs if there is a history of deep diving compression syndrome or compression embolism, and also thrombus. It is always in the state of hypercoagulability, and bacteria in infectious cause, amniotic fluid in a pregnant ladies, and also tumor in a person with malignancy. So fat emboli associated with long bone fractures and liposuction. It represents with classic triad of hypoxemia, neurologic abnormalities, and pedicel rash. So we have to remember this triad. So fat emboli normally presents with a classic triad of hypoxemia, as I said already earlier, decreased partial pressure of oxygen less than 60 mm of Hg, and neurologic abnormalities, and also pedicel rashes. And air emboli, which is nitrogen bubbles precipitate in ascending divers, as I said earlier, which is also called Caisson's disease or decompression sickness. We have to remember this. This is very high yield. You can note it down. Caisson's disease, decompression sickness, and it is treated with hyperbaric oxygen therapy. This is classic feature. Feature as in treatment is very classic in this case, hyperbaric oxygen therapy, or it can be iatrogenic, that is secondary to invasive procedures like central line placement. You can if when as a doctor, if we inject a person with an injection, we have to ensure that there is no air left in that injection by pumping it into the air in the blank space before we place a central line. So that may cause air embolism too. So that is very risky. And also amniotic fluid emboli typically occurs during labor or postpartum, but can be due to uterine trauma too, and it can lead to DIC. DIC is disseminated intravascular coagulopathy. It is very rare, but it presents with very high mortality. That is what it is. And then here are lines of Zahn. If you can see, these are lines of Zahn, alternating red and pink, right? These are lines of Zahn. So there is mediastinal pathology. What is mediastinum? Normally, mediastinum is a region that underlies heart. It is a region between two lungs. So that is mediastinum. Mediastinum are divided actually into anterior mediastinum, then posterior mediastinum. So mediastinum normally contains heart, thymus, lymph nodes, esophagus, and aorta. So if there is any pathology like mediastinal masses, mediastinitis, pneumomediastinum, it may present with a very large spectrum of clinical features. So mediastinal masses, some pathologies with mediastinal masses are lymphoma, lung cancer, abscess. Obviously, since there is masses, there should be something other than our normal compartment, normal organs. So they can occur in any compartment. As I said, they can occur in anterior compartment, middle, or posterior compartment. But there are common associations. In anterior compartment, there is 4 T's, because thyroid is in our anterior region. That can occur, substernal goiter, and also thymoma or thymic neoplasm, and then teratoma, and then terrible lymphoma. So basically, terrible lymphoma, it is just lymphoma, but we can make a mnemonics out of it. So we turned it into terrible lymphoma. So in anterior region, there is a very high risk of mediastinal masses from 4 T's, 4 T, and 1T out of it is thyroid, that is substernal goiter, and then thymic neoplasm or thymoma, then teratoma, then terrible lymphoma. So in compartment, middle compartment lies heart, and it is metastasis, hiatal hernia, and also bronchogenic cysts. And in posterior region, there is esophageal cancer, because obviously esophagus trachea lies in the posterior region. Esophageal cancer may present as mass in or spread to middle mediastinum, and neurogenic tumor like neurofibroma, also multiple myeloma, may present mediastinal masses. So in mediastinitis, it is normally itis is inflammation. We all know that, and the inflammation of mediastinum is mediastinitis. Mediastinal tissues is mediastinitis. It is commonly due to postoperative complications of cardiothoracic procedures, commonly due to postoperative complications of cardiothoracic procedures less than 14 days, and then also esophageal perforation may cause mediastinitis, common with repetitive vomiting like Burhap syndrome, or also Mallory West-Air, or contagious spread of odontogenic and retropharyngeal infection can also cause mediastinitis. There is chronic mediastinitis, also called fibrosing mediastinitis, due to increased proliferation of connective tissue in mediastinum. So we can remember this too. Chronic mediastinitis is also called fibrosing mediastinitis due to increased proliferation of connective tissue in mediastinum. And then histoplasma capsulatum is common cause, right? What is the common cause of chronic mediastinitis? That is histoplasma capsulatum. It is a fungi. And the clinical features include fever, tachycardia, leukocytosis, chest pain, and external wound drainage. All the classic features of inflammation. And pneumomediastinum, pneumo means air, so there is air trapped in mediastinum, that is pneumomediastinum. Presence of gas, usually air in the mediastinum. It can either be spontaneous due to rupture of pulmonary valve. What is pulmonary valve actually? Pulmonary valve is, for example, let's say this is our lungs, and there is a small small number of bubbles in there. These bubbles include air in there. It is actually a classic feature of emphysema. So emphysematous lung have subpleural valves, extremely very much amount of subpleural valves, and if they are complicated, then these subpleural valves rupture, causing pneumothorax also. And if they rupture, it can cause pneumomediastinum too. And if that has secondary cause or etiology, that can be due to traumatic iatrogenic or Burhap syndrome. Burhap syndrome is repetitive vomiting, and that is what Burhap syndrome. It can cause esophageal tear, and then the air can rush into the mediastinum. And ruptured alveoli allow tracking of air into the mediastinum via peribronchial and perivascular sheaths, that you can remember. And also the clinical features of pneumomediastinum is chest pain, dyspnea, voice change due to compression of recurrent laryngeal nerve due to air filling, and also subcutaneous emphysema, which I talked about it, and also positive Hammond sign, which is crepitus on cardiac auscultation. When we auscultate our cardiac region, we hear crepitus. Crepitus is a sound, right? And that can cause crepitus is a breath sound, and that is also called Hammond sign. That is how we tapped into our mediastinal diseases. We now go to the flow volume loop. Flow volume loop actually helps us to identify or distinguish between obstructive lung disease and also restrictive lung disease. Let me tell you something about this crepitus. Crepitus is also a breath sound, and it is caused when collapsed or fluid-filled air sacs abruptly open when you breathe. That is crepitus, right? And also, so they can either be coarse crackles or also crepitations is also called in their other name, and then it is associated with bronchiectasis or resolving pneumonia too, whereas fine crackles can be heard with either pulmonary edema or interstitial fibrosis. That I wanted to give you a background information on crepitus. And also there is flow volume loops. These flow volume loops helps us to distinguish between obstructive lung disease and also restrictive lung disease. So flow volume loop, there is a flow of air into and out of lungs, and then the volume of total volume of air, that is what is the flow volume loop. So there is something called RV, that is residual volume. In normal, we do not talk normal in here. The obstructive lung disease, the residual volume increases because the air that we need to exhale is not being exhaled. That is why the residual volume is increased. And so obstructive lung disease is a disease of expiration. There is extremely tough expiration, tough to expirate. And then restrictive lung disease, we cannot inhale the air, that is inspiratory disease, right? And then FRC is forced residual capacity, that is increase in obstructive lung disease and decrease in restrictive lung disease. Obviously total lung capacity, since the air is being trapped inside lung and there is no exhalation, obviously it increases in obstructive lung disease and it decreases in restrictive lung disease. And it is FEV1, that is forced expiratory volume at first second, it is greater than 80% is predicted in normal, but it is decreased in obstructive lung disease very much. It is decreased in both disease, but it is very much decreased, it is extensively decreased in obstructive lung disease. And then forced vital capacity, it is also normal or decreased in obstructive lung disease and also in restrictive lung disease. So FEV1 by FBC ratio, this is a single parameter that defines whether it is an obstructive lung disease or restrictive lung disease. If it is greater than 0.7, then we can say actually normal ratio is almost 0.7, so that is 70%. And obstructive lung disease, this FEV1 by FBC ratio gets decreased. FEV1 decreased more than FBC, right? So there is disproportionate decrease of FEV1 to FBC that leads to decrease in FEV1 by FBC ratio. But in restrictive lung disease, the FEV1 decreases proportionately to FBC, so it may present with normal ratio. So if FEV1 by FBC ratio is normal in any of the restrictive lung disease like interstitial fibrosis or fibrosing lung diseases, we cannot say that it is a normal case because there is decrease in both FEV1 and FBC in a same proportionate ratio, which is leading to 0.7. Right? So this is a misinformation, but usually it is increased in restrictive lung disease. And you can see in here these flow volume loops. 6 liter of air is present in inspiration case with expiration in 2 liters, right? There is total lung capacity, that is 6 liters. 6 minus 2, 4 liters. We just breathe 4 liters in here, and residual volume is 2 liters in here, and in vital capacity is also 4 liters in here. So basically in obstructive diseases, this loop shifts to the right. So 8 liters of air is trapped into the lungs and 4 liters, this right here is residual volume. We have 2 liters of residual volume here, but we have 4 liters of residual volume here. So total of 8 liters of 8 liters of air should be there, is normally there in obstructive lung disease. And in respiratory lung disease, this loop shifts to the right. There is decreased in residual volume, and also there is only 4 liters, like this 3 liters of air in our lungs. That is what it is. So let's go tap into the obstructive lung diseases. There are classic examples of obstructive lung disease. We will tap into each of them. So obstructive lung disease, it is also obstruction of airflow, decreased FEV1, FBC, FEV1 by FBC ratio, as we talked earlier, that leads to air trapping in lungs. So increase in RV, and also increase in forced residual capacity, and also increase in TLC, total lung capacity, due to premature airway closure at high lung volumes. This is the pathology. premature airway closure at high lung volumes, and it includes COPD, chronic bronchitis, emphysema, asthma, and bronchiectasis. These all are obstructive lung diseases. So COPD is chronic obstructive pulmonary disease, often due to tobacco use. Most common etiology is tobacco use. Smoking normally affects almost each and every organ of our body, right? So smoking is the worst thing that we can do. It is most important risk factor, and also pollutants and allergens can cause COPD. It includes chronic bronchitis and emphysema, which often coexist, and exacerbation causes acute worsening of symptoms is exacerbation, often associated with viral or bacterial upper respiratory tract infection. So let's go into the chronic bronchitis. We will read about chronic bronchitis, then emphysema, chronic bronchitis, then emphysema, then also asthma. We'll read about this bronchiectasis. These are COPD, right? We'll talk about this earlier. And so chronic bronchitis has a clinical diagnosis. So criteria is we have to remember this exact number. There should be productive cough for greater than 3 months in greater than 2 consecutive years. That is the clinical diagnosis of chronic bronchitis. There is a very large amount of sputum that is formed in chronic bronchitis actually, right? So it may also have dyspnea, wheezes, and wheezes are crackles due to mucus, and cyanosis due to hypoxemia. So dyspnea, difficulty in breathing, wheeze is a breath sound hard in auscultation. Like crackles is due to also mucus, and cyanosis, hypoxemia due to shunting. There is shunting of blood, and then secondary polycythemia. Why secondary polycythemia? There is a pathophysiology for this. Since there is decrease in oxygen supplied to the RBCs, the kidneys sense that there are decreased oxygen, right? And then it releases erythropoietin hormone, EP, and that causes the increase in number of RBC synthesis. So basically there is secondary polycythemia, and the COPD also leads to metaplasia of pseudostratified ciliated columnar epithelium into stratified squamous epithelium. So metaplasia, as we talked in our general principles, it normally occurs if the existing type of epithelium cannot sustain the insult causing by the disease, then the more powerful kind of epithelium replaces that. So that is what happened here. Pseudostratified ciliated columnar epithelium is replacing stratified squamous epithelium, right? So the mechanisms of chronic bronchitis is hypertrophy and hyperplasia of mucus secreting glands in bronchi. Here we can see Reed's index. This is very high yield. Increase in Reed's index. Increase in Reed index is thickness of Reed's index is actually the ratio between thickness of mucosal gland layer to thickness of wall between epithelium and cartilage. So that is the ratio, and it increases to greater than 50% in the case of chronic bronchitis. We have to remember this, right? So let's tap into the emphysema. Emphysema has a radiologic or biopsy diagnosis. In radiology, we see barrel chest normally. So okay, here I can add a thing. The patient of chronic bronchitis are also called blue bloaters, right? Because there is cyanosis. They are also called blue bloaters. And then in emphysema, they are also called as pink puffers because they breathe through pursed lips, and the chest X-ray shows barrel chest that is increased anteroposterior diameter, best seen in lateral X-ray, and a flattened diaphragm is there, and increased lung field lucency is there. So here you can see here this X-ray, right? This X-ray right here, you can see emphysema. And also there is a The mechanisms of this emphysema is alveolar wall destruction, which leads to the increased compliance of lung, decreased recoil, and damage to alveolar capillary membrane that causes DLCO. Decrease in DLCO results in increased air space. So basically, here is this feature right here. That is the permanent dilatation of alveoli. Actually, what happens is if somebody breathes, right? If we breathe right here, this is an alveoli. This gets enlarged like this. Then in exhalation, this should turn back to this normal, right? But in emphysema cases, it doesn't turn back to normal and gets permanently dilated. So that is what emphysema is, because there is alveolar wall destruction and decrease in increase in compliance of lung, and there is decrease in recoil due to elasticity decrease. So that is what it happens. So basically, DLCO right here is also clinical feature. There is decreased diffuse alveolar capillary damage, right? So it reduces DLCO. Diffuse alveolar capillary damage reduces DLCO. And the emphysema have different types. These types of emphysema are centriacinar, panacinar, and also there is distal emphysema and paraseptal emphysema. There are 4 types of emphysema: centriacinar, panacinar, distal emphysema, and paraseptal emphysema. So that is what it is. So centriacinar spares distal alveoli, frequently in upper lobes. So classic feature of centriacinar is upper lobes and associated with tobacco smoking. And panacinar affects respiratory bronchioles and alveoli, frequently in lower lobes. So difference between centriacinar and panacinar is that they affect in upper lobes and panacinar affects in lower lobes. It is associated with alpha-1 antitrypsin deficiency. So basically, alpha-1 antitrypsin is something that limits the degradative feature of trypsin, which is an enzyme, right? So if there is alpha-1 antitrypsin, there is increase in trypsin enzyme that causes the destruction of proteins of our lungs. So that is what it is. So if you are still confused with DLCO right here, because I am confused with DLCO. So DLCO is actually diffusing capacity of the lungs for carbon monoxide. D for diffusing, L for capacity of lungs of carbon monoxide, that is DLCO. It is also known as transfer factor for carbon monoxide, which is TLCO, and it measures the amount of carbon monoxide transferred per minute from alveolar gas to red blood cells, RBCs. That is what we have to remember. That is DLCO, and it gets decreases in emphysema. Let's go into the continuation of obstructive lung disease. So actually, emphysema is mediated by oxidative stress, chronic inflammation, CD8 plus T cells, neutrophils, macrophages, and imbalances of proteases and antiproteases. That is increase in elastase activity, and that leads to the decrease in elastin protein, and that leads to, as I said, loss of elastic fibers. So alveolar destruction is there. So this dilated alveoli cannot recoil back and cause the permanent dilatation, and if it increases, that will cause the blebs, which is bubbles, and if that is also complicated, the blebs rupture, causing pneumothorax, and you see hyperinflation in lungs. So let's go to the asthma. Bronchial asthma is a very common disease diagnosed in these days, and it is intermittent obstructive lung disease, often triggered by allergens, viral upper respiratory tract infections, stress, and they are associated with atopy. And also there is NSAID or aspirin exacerbated respiratory disease, asthma, nasal polyps, and COX inhibitor sensitivity, which causes leukotriene overproduction, and then airway obstruction, that is Santer's triad. You have to remember this, Santer's triad, right? So the diagnosis of asthma is clinical diagnosis. There is intermittent episodes of dyspnea, coughing, wheezing, and tachypnea. The wheezing is a musical sound heard in auscultation. This is very high yield. And also diagnosis is supported by spirometry, obstructive pattern with bronchodilator response, but may be normal when not in exacerbation. Plus minus methacholine challenge. Methacholine challenge, right? Methacholine is cholinergic, anticholinergic drugs or antimuscarinic drugs. So the mechanisms of asthma is type 1 hypersensitivity reaction pathogenesis, and it causes smooth muscle hypertrophy and hyperplasia, that is constriction of bronchial bronchus and thus difficulty in breathing. Hyperresponsive bronchi causes reversible bronchoconstriction, and also there is mucus plugging. In figure E, A, B, C, D, E, there is mucus pluggings. And in histology, we see Crossman spirals in asthma, right? We also see Crossman's spiral in sputum. So that is it. And the other E, I have already said Crossman spirals. F, said epithelium forms hold mucus plugs. There are hold mucus plugs like this. There are hold mucus plugs. You can see Crossman spirals. These are Crossman spirals right here. And also Charcot-Leyden crystals. These are eosinophilic hexagonal double-pointed crystals formed from breakdown of eosinophils in sputum. These are Charcot-Leyden crystals. These two features right here, Crossman spirals and Charcot-Leyden crystals, these are very important. These are Charcot-Leyden crystals, and this is Crossman spirals. So Charcot-Leyden crystals are formed from eosinophilic hexagonal double-pointed crystals from breakdown of eosinophils in sputum. So we are now tapping into bronchiectasis. Bronchiectasis is also obstructive lung disease. It is most commonly associated with cystic fibrosis. Cystic fibrosis is an autoimmune disease where there is antibodies present in CFTR against CFTR, that is cystic fibrosis transregulator protein. So bronchiectasis is diagnosed, characterized by chronic cough and daily purulent sputum production, and then it often have recurrent pulmonary infections. They are confirmed by imaging demonstrating airway dilation, bronchial thickening, and they are supported by obstructive pulmonary function test pattern. This means there is a increase in RB, increase in FRC, decrease in FEB1, decrease in FBC. That is what it is, obstructive pulmonary function test pattern. So it is confirmed by imaging demonstrating airway dilation, right? And also bronchial thickening. Pathophysiology is initial insult of pulmonary infection combined with obstruction or impaired clearance, which cause dysregulated host response, causing bronchial inflammation, causing permanently dilated airways. So if the airways are small and they are permanently dilated, that is emphysema. But if there are larger permanently dilated airways, that is bronchiectasis. There is many etiologies, including airway obstruction, that is foreign body aspiration or mass, poor ciliary motility, age in tobacco, smoking, and Carter syndrome, and also cystic fibrosis. In cystic fibrosis, we have, I just wanted to say this because I just remembered it. In cystic fibrosis, we do sweat chloride test because there is very high amount of chloride loss. That is why we do sweat chloride test as diagnostic feature. And in figure H shows a coughed up inspissated mucus plug, that is coughed up inspissated mucus plug right here, and it is allergic bronchopulmonary aspergillosis, pulmonary infections, that is Mycobacterium avium. These are the notes for bronchiectasis. That is how we complete our obstructive lung disease. Now we will tap into respiratory lung diseases and idiopathic pulmonary fibrosis, respiratory lung disease, idiopathic pulmonary fibrosis, and then hypersensitivity pneumonitis, and also we will do sarcoidosis. So basically, let's go into the restrictive lung disease. I have a habit of saying basically, so don't get tired of this, right? So are you still here with me, or did you just lose the patience and go? So we had to have the patience and resilience to uh, crack this USMLE, right? So restrictive lung disease may lead to decreased lung volumes, that is decreased in FBC and TLC, and PFTs may be normal or increased FEB1 or FBC ratio is seen in restrictive lung disease, and patient presence with short shallow breaths, crackles, that is Velcro type of crackles. There are Velcro type of crackles in restrictive lung disease, and there are types of restrictive lung disease that is altered respiratory mechanics and also diffuse parenchymal lung diseases. So if there is all altered respiratory mechanics like extrapulmonary, normal DLCO, normal alveolar arterial gradient, so these are either respiratory muscle weakness or chest wall abnormalities. So respiratory muscle weakness, so shown by polio, myasthenia gravis, and also Guillain-Barré syndrome, and then amyotrophic lateral sclerosis. This cause respiratory muscle weakness, so diaphragm cannot contract so well, and it causes restriction in breathing. That is also restrictive lung disease. And there is chest wall abnormalities like scoliosis and severe obesity that can also cause restrictive lung disease. So diffuse parenchymal lung diseases, also called interstitial lung diseases, these are pulmonary cause. These are extrapulmonary cause right here, and this is pulmonary cause. And decreased DLCO, diffusing capacity of lungs for carbon monoxide, and also alveolar arterial gradient. There are many causes like this. Pneumoconiosis being the very most common cause, pneumoconiosis, including co-workers pneumoconiosis and silicosis, asbestosis. Then we have sarcoidosis, bilateral hilar lymphadenopathy is the classic feature. Co-workers pneumoconiosis, we will talk about these all in details. And the non-caseating granulomas, increased in ACE enzyme, and then increase in calciums. So idiopathic pulmonary fibrosis, granulomatosis with polyangiitis, pulmonary Langerhans cell histiocytosis, which typically present eosinophilic granuloma, and also hypersensitivity pneumonitis, drug toxicity, bleomycin, busulfan, and amiodarone methotrexate, ARDS, acute respiratory distress syndrome, and radiation-induced lung injury, associated with pro-inflammatory cytokine release, right? Pro-inflammatory cytokine release. Example, TNF-alpha, interleukin 1, interleukin 6, and may be asymptomatic, but most common symptoms are dry cough. And then dyspnea with or without low-grade fever. Acute radiation pneumonitis develops within 3 to 12 weeks, that is in exudative phase, and radiation fibrosis may develop after 6 to 12 months. So this is the timeline. You have to remember this, right? So idiopathic pulmonary fibrosis, let's tap into that. Idiopathic pulmonary fibrosis, it is progressive fibrotic lung disease of unknown etiology. Since it is idiopathic, it is obviously unknown etiology, and then it may involve multiple cycles of lung injury, inflammation, and fibrosis associated with tobacco smoking, environmental pollutants, and genetic defects. The findings in idiopathic pulmonary fibrosis is progressive dyspnea, then fatigue, non-productive cough, and then crackles, cloving. So cloving is actually, we do a sign called Samroth sign to assist cloving. Cloving is the hypertrophy of nail beds, right? Samroth signs, it is a sorry. There should be diamond-shaped space between two thumbs when they are arranged laterally, right? So there should be diamond-shaped space. If there is no diamond-shaped space, that is called cloving. So cloving is assessed with Samroth sign. Imaging shows peripheral reticular opacities with traction bronchiectasis, with or without honeycomb appearance of lung in advanced disease. So honeycomb appearance of lung in idiopathic pulmonary fibrosis. This is very high yield. We have to remember honeycomb appearance of lungs. Histologic pattern shows usual interstitial pneumonia, decreased type 1 pneumocytes, and increased type 2 pneumocytes, which lead to the increase in surfactant levels and also increase in fibroblasts. The complications of pulmonary fibrosis include pulmonary hypertension, right heart failure, arrhythmias, coronary artery disease, respiratory failure, and lung cancer. So in hypersensitivity pneumonitis, there is mixed type of hypersensitivity, not third, not fourth. There is type 3 and type 4 hypersensitivity reaction to environmental antigens such as thermophilic actinomyces, myces, or aspergillus. Aspergillus is a fungi, right? So often seen in farmers and bird fanciers, since aspergillus is mostly found in field, and also acutely causes dyspnea, cough, chest tightness, fever, and headache. But in chronic case, and it is also self-limiting, right? Causes dyspnea, cough, chest tightness, fever, and headache. But in chronic case, it causes irreversible fibrosis with non-caseating granuloma, alveolar septal thickening, and traction bronchiectasis. These are the symptoms of hypersensitivity pneumonitis. So let's go to the sarcoidosis, and then we will go to the mesothelioma. Mesothelioma is the malignancy of the pleura associated with asbestosis. So sarcoidosis, it is characterized by immune-mediated widespread non-caseating granulomas. Actually, there are caseating granulomas in infections like caused by Mycobacterium tuberculosis, right? So there is non-caseating granulomas. It is also immune-mediated in sarcoidosis, and there are elevated serum ACE levels and elevated CD4, CD8 ratio in bronchoalveolar lavage, like you can see in here. Elevated bronchoalveolar lavage fluid. It is more common in black females, often asymptomatic except for enlarged lymph nodes, and chest X-ray shows bilateral adenopathy and coarse reticular opacities. In B, yes, there is coarse reticular opacities, and then also ground glass opacities are seen. CT of the chest better demonstrates the extensive hilar and mediastinal adenopathy. This here, this is the hilum region. This is causing hilar or mediastinal adenopathy, right? Adenopathy is the inflammation or the infection of glands, and also it is associated with Bell's palsy, parotid enlargement, granulomas, that is non-caseating epithelioid containing microscopic Schaumann and asteroid bodies. This is very high yield, and also rheumatoid arthritis like arthropathy, increased calcium, ocular uveitis, interstitial fibrosis, vitamin D activation, that is due to increase in 1-alpha hydroxylase in macrophages. 1-alpha hydroxylase is an enzyme used to the formation of vitamin D, and skin changes like lupus pernio or erythema nodosum, that is sarcoids. This is the mnemonics here. So association should be remembered like this, and the treatment is glucocorticoids if it is symptomatic. And mesothelioma, it is malignancy of the pleura associated with asbestosis. As I said earlier, mesothelioma has a very high risk factor with asbestosis, and histology may show samoma bodies. That we talked about it earlier in our general principles, the mnemonics, and also EM may show polygonal tumor cells, often microvilli, desmosomes, tonofilaments, and calvitinin and cytokeratin 5-6 positive in almost all mesotheliomas, and absence in most carcinomas. So tobacco smoking is not a risk factor for the case of mesothelioma. And pneumoconiosis, this is our last topic for today. Pneumoconiosis is asbestos is from the roof, was common in insulation, but affects the base, that is lower lobes. Silica, coal, and berries are from the base, that is earth, but affect the roof, that is upper lobes, right? Asbestos is from the roof, was common in insulation, right? Insulation of wires, so asbestos, but affects the base of the lungs. But silica, coal, and berries, they are found in earth, that is base, but they affect the roof of the lungs, that is upper lobes. We can remember like that. Asbestos related disease. Asbestos causes asbestosis, pulmonary fibrosis, pleural disease, malignancies, and they have shipbuilding and roofing, plumbing is very much associated with this disease. And also ivory white calcified supradiaphragmatic and pleural plaques are pathognomic, like this ivory white, right? These red arrows are showing these regions. And risk of bronchogenic carcinoma is greater than risk of mesothelioma in asbestosis-related disease, and increased risk of Kaplan syndrome, which is rheumatoid arthritis, pneumoconiosis, and intrapulmonary nodules. And then they affect lower lobes. Asbestos, which is ferruginous bodies, are golden brown fusiform rods resembling dumbbells found in alveolar sputum sample visualized using Prussian blue stain, often obtained by bronchoalveolar lavage, there is a risk of pleural effusions. This right here is ferruginous bodies. It has an iron overload, right? And in berylliosis, there is associated with exposure to the beryllium in aerospace and manufacturing industries that causes granulomatous, that is non-caseating granulomatous inflammation. And on histology, will look like this. It looks like this, and it affects upper lobes. And in co-occurrence pneumoconiosis, there is prolonged coal dust exposure that causes macrophages laden with carbon and inflammation and fibrosis. It is also called as black lung disease, that is increased risk of Kaplan syndrome, as I said earlier, rheumatoid arthritis and pneumoconiosis with intrapulmonary nodules. We will do that for now. Thank you.